This is an event hosted by Because Mental Health, which is a youth-led publication and volunteering organization that aims to end the stigma against mental health and increase education of youth in the realms of psychology and neuroscience. Today, we are very grateful and honored to have Ms. Zsofia Szlamka with us, who is the founder of AMK Counseling. Zsofia is a developmental psychologist and an advocate for equal opportunities and education. Without further ado, we would like to pass the time to Zsofia.
I'm going to speak about my career journey so far, and I'll tell you about what we do at AMK Counseling, what I'm doing as part of my PhD, and what I'm doing as a volunteering activity in the mental health space. And then I will just open it up for questions, and then we can see what you think about it, what you're more interested in hearing about. And then in terms of internet connection, I don't expect any problems to occur, but if at any time point you don't hear me well, you don't see me well, just advise me, and then I'll make sure to either reconnect or change rooms, and we'll figure it out. So I'm a psychologist. I specialize in developmental psychology. What this means is that I specialize in the psychology of early development and from early young children to the teenage years. And I specialized in autism spectrum disorder and other neurodevelopmental conditions. So what this means is that I first did a bachelor program in psychology, then a master's in social and developmental psychology, specializing in autism spectrum disorder. And then as part of my PhD, I also specialize in autism spectrum disorder and other neurodevelopmental conditions. So this is the career path that I've been doing so far. However, I never started my career with psychology. When I was around 18 years old, I thought that I was very interested in journalism and humanities. So I basically first started back in Hungary a degree in journalism and in humanities. I studied my minor. In Hungary, we have majors. You have your major and then your minor in something else. And that minor program for me was French medieval literature. So really quite far removed from psychology or what I'm doing right now. And then during my first year, I realized that I was really missing more human interaction as part of my work. And so this is why I decided to then change to psychology. At the time, I was really lucky because the Hungarian government had a scheme for students who had good grades in university, and you could apply and do a second bachelor's program governmentally funded. The year after me, they closed this scheme. So I was really quite lucky that I could still do this. And so this is how I completed my bachelor degree in humanities and then in psychology as well. I really wanted to highlight this because I think quite a few of you are before making career choices and career decisions. And I think it's important that at a young age, we might not yet know what works best for us. And so it's okay, you can make different choices later in life. It is likely to happen, and you can shift careers as you go along the way. And so during my bachelor's, I did practicals and internship schemes in different aspects of psychology. I interned in occupational psychology, in organizational psychology. So I worked a bit in HR, in recruitment and training and onboarding employees to big organizations in the corporate world. I worked in education a little bit. That was another internship. I was working on a continuing education program for as part of an Erasmus Plus, or a European collaboration for continuing education. And then I did a clinical psychology practical first in an adult psychiatry and then in a child and adolescent psychiatry. And basically by working in different areas of psychology, I realized how interested I was in child and adolescent psychology and especially psychology at those very early ages when development is still very, very active, very quick. we call it neuroplasticity when the brain is still very much prone to changes and development. And so basically, it's again something I would recommend to anyone to try and do as many different practicals, internships, try yourself out in different spaces so that you get to know what you're actually interested in doing and what you're not that interested in doing. So basically, once I completed all these practicals, I was very interested in clinical psychology. And the reason why I decided to specialize in autism spectrum disorder and other neurodevelopmental conditions is because when I was working in this hospital, one day, it was a Wednesday. I will never forget that it was a Wednesday. I was in the psychiatric ward. I was helping out with some of the group sessions that took place that day. And the ambulance took a 17-year-old boy to the hospital whose only way of communication was to undress. He did not have verbal skills. He did not have any other means of communication. He was really frustrated, aggressive, and as you can imagine, a 17-year-old boy, when frustrated, can really be physically, he could easily hurt others physically, even unintentionally. And so this boy got diagnosed with autism spectrum disorder in the hospital, but we also realized that there was not much that we could have done at that point. At that age, neuroplasticity, so that part of brain development when early intervention could be helpful, had already passed. There was very little we could do. And so that experience made a huge impact on my career decisions. That's why I decided to specialize in autism. I knew very little about the condition, even though I had been studying psychology for a while then. And I also realized that in my country, Hungary, awareness about autism and other neurodevelopmental conditions, and then broadly speaking, awareness of mental health conditions was really low. So that's how my commitment was born to the field. And so basically I stayed then in this psychiatric unit, and I worked in an autism diagnostic center where we would see families coming to us for consultation to see whether their children have any neurodevelopmental conditions. And so I got a lot of training there in terms of observation skills, diagnostic skills. And then later on, I did, after my bachelor, I did a year. I went to Latvia in the Baltic countries. I moved there for a year. I was doing an Erasmus program there, and I worked, it's called the European Voluntary Service. So I volunteered in a social center for children from underprivileged backgrounds, and in a disability center for people with serious chronic mental disease or with serious chronic neurodevelopmental disorders. And so this was the first time that I could see cross-cultural differences in the stigma around mental health, and also in how mental disorders and mental health problems would be stigmatized in different countries. What I saw in Latvia at the time was that there was, compared to Hungary, even less awareness of these conditions, even less information made available. And there was, generally speaking, there was an atmosphere in which mental disorder would be perceived as something ultimately medical, something that would ultimately have to be institutionalized. And that means that people with mental health problems would be living in separated buildings, in separated institutions, and they would be quite far removed from the general society. And it was quite, I guess, interesting for me to see that, because as a psychologist, what I was learning was how we can include people with differing levels of mental health problems or chronic diseases in society. And so I could really not see that happening in Latvia at the time. Then the next year I moved to the UK. So that's where I did my master's in social and developmental psychology. And I still specialized in autism spectrum disorder. In my master's, I studied the female experience of living with autism. So another interesting component to neurodevelopmental disorders, and generally speaking to mental health conditions, is that there can be gender discrepancies in the prevalence rate of these conditions. Gender discrepancy just means that there might be differences in how certain symptoms manifest for men and women, or the lived experience of those symptoms might differ, and society might look at these symptoms differently as well. It does not mean that biologically speaking there would be differences in these mental health conditions, but the way in which these symptoms manifest, the lived experiences of them, and how society perceives them can be different. And prevalence rate, what that means is the frequency of a condition happening in the general population or in society. So in my master's, that's what I studied, the female experiences of living with autism spectrum disorder. And I did this in the UK, but I did some fieldwork in Scotland and then some fieldwork in England to study the female experience of living with autism. And so my interest in cross-cultural psychology had become even stronger than being able to see how mental health is viewed in Western Europe, in the UK, in Central Europe, where I come from, and in Eastern Europe, in the Northeast of Europe, in Latvia, where I did this exchange program. And so after my master's, I did then get the opportunity to work with the World Health Organization as part of an internship for a couple of months. And so I got a scholarship to be able to go to Geneva. So I was there, and I worked in the Department of Mental Health and Substance Abuse. And so it was very interesting because it was the first time for me to see how mental health works on the policy level, how mental health is tackled in the headquarters of a United Nations agency that is hoping to spread the word in countries worldwide about mental health and mental disorder included. And so that was the first time that I came across the field of global mental health. I never studied about it before in my psychology degree. By this time, I had completed my master's. I still knew nothing about global mental health as a space. And so can you raise your hand, please, if you have heard about global mental health before, or if you read about it? Can you raise your hand if you have never heard about it before? You can use the chat the reactions function on Zoom to do this. All right, I'm just going to assume you haven't heard about it, and I'll tell you a bit more. So basically, the field of global mental health arose in the early 2000s. It was launched by a commission in the Lancet Psychiatry, which is one of the very highly valued journals for global health. And so in this commission that was published in 2007, international psychology, global health, and psychiatry scholars talked about the fact that while the burden of disease of mental health conditions and neurodevelopmental conditions is very high worldwide, the vast majority of people who live with such conditions live in low and middle income countries, and they do not have access to services. And they call this to be the treatment gap. So when they launched the field of global mental health, they identified this treatment gap, and they said that professionals who work in global mental health, in cross-cultural psychology, in international development, but in the mental health space, should be targeting to close this treatment gap and support those who are misdiagnosed, who are undiagnosed, or who would be diagnosed correctly, but who would not have access to services for the condition that they are living with. And so they suggested that by scaling up services that exist and that are evidence-based, and by implementing them in different income settings, that's how we would be able to provide service access to communities worldwide. Global mental health also stands for the idea that we should be relying on non-specialist support to provide access to services. What this means is that very often global mental health interventions would rely on a training the trainer approach. So, for example, there would be me as a psychologist, some other psychologists, and then we would train social workers, community health workers, psychiatric nurses on a specific intervention, for example, on preventing depression among young people. And then these non-specialists who don't have a sort of formal specialist education in mental health could then go on to the general, to the community and then deliver that intervention locally. And so by relying on this train the trainer approach and on scaling up services, global mental health as a field suggests that this is how we are able to provide services worldwide in different settings, different resource settings. So it was here in the World Health Organization that I learned about this field for the first time. It was something really new to me, but I loved the idea that we could bring interventions, we could bring knowledge to different parts of the world where mental health would be more highly stigmatized, where there would be no services available, or there would be some diagnostic services available, but there would be no follow-up therapy or follow-up services. And in fact, I related a lot of this to my experience in Hungary. So I come from the capital city, Budapest, where there are services available. But for example, when I worked in this diagnostic unit, many times we would have families coming from rural areas and even Hungarian-speaking parts of other countries, such as Romania or Serbia, who would come to us in the capital city in Hungary so that they receive services. Otherwise, locally, they would not have access to diagnostic services at all. So I thought it would really make sense to support service development in different resource settings. And not only do I mean this from a financial perspective, but also from a geographical perspective. Do I have to travel far away in order to access services? Am I able to afford transportation? How much time does it take? Can I take a day off from work to be able to go and access services? So answering questions like this. And so in the World Health Organization, I was working on a program called the Mental Health Gap Action Program. I'll send the name of it on the chat. If you're interested in this space, I warmly recommend that you check it out. This is the flagship mental health program developed and designed by the World Health Organization. It consists of several modules of mental health, from depression, mood disorders, stress and anxiety, childhood developmental conditions, to more severe psychiatric conditions such as psychosis and schizophrenia. And it provides scalable and easily feasible interventions for different income settings. It's freely available. And the core goal is that this intervention guide and the intervention itself is implemented and sustained in public health systems around the world. So I was working a little bit on this program. As an intern, I worked on the depression module. Of course, my role as an intern was not very, very big. I was working on educational components of the intervention guide, but nevertheless, it was a really interesting learning experience for me. After the World Health Organization, I went on to work in a center called the Winton Center for Risk and Evidence Communication in the University of Cambridge. This was somewhat removed from what I was doing earlier. I was not working on autism. I was working on how we communicate risks and quantitative information in healthcare, how to communicate prevalence data, how to communicate side effects of different therapies, different medication options, even to those receiving services. And so what I learned there was the communication component to healthcare options, how to communicate using easy language, how to double check how other people understand numbers that I would be communicating to them. And then after that, I started my PhD in King's College London, where I'm still doing this PhD. I have a few months left to write up. And this is where I went back to studying autism spectrum disorder, but from a broader perspective. So I study service development for families who raise children with developmental disorders in a cross-cultural setting in Ethiopia and in Argentina. The most frequent question that I get about this is, why these two countries? Ethiopia, because when I met my supervisor, I met her on a talk that I attended. And on this talk, she presented her research in Ethiopia. And I thought, which was about caregiver interventions. And I had never been to the African continent. I knew close to nothing about Ethiopia. And I thought it would be an interesting challenge for me to onboard on her research team and work in this setting. And Argentina, somewhat for personal reasons, I had been there before, I did some work there before, and it made sense for me to do a cross-cultural analysis. I thought it would be an interesting case to compare two countries and two regions that are not otherwise compared or associated in research and practitioner settings. There's quite some research about mental health and developmental disorders on the African continent. There's quite a lot from South America as well, but there's very, very little cross-comparative analysis. So I thought it would be an interesting study. And then, so this is exactly what I did. I spent a few months in Ethiopia. I spent a few months in Argentina. This is where COVID hit the world. This is where remote work really started. And so in this cross-cultural study, I was really looking at the concepts of empowerment of families, the gender components of caregiving as a task, as a typically female task in various countries and cultures, and then how we can use service development and empowerment to support these families so that they can give the best of access to services to their children. And so when COVID hit the world, students in the UK were advised to go back to their home countries. I did that as well. I went back to Hungary. And I thought that this was the first time that, in my life at least, when a global event happened that put everyone's mental health at risk. And so when I started my psychology training, we had to sign we had to vow to some ethical principles for psychologists. The first one of them being that we as psychologists would support those in need. And so I thought that this was literally the professional and moral call for me to act. And so in Hungary, this is how we started a crisis mental health program. We provided brief counseling sessions remotely to those who needed it, typically students, typically university students, and then some professionals who had families and they were in lockdown with young children at home in a tiny space. And so we were volunteer psychologists, clinical psychologists, counseling psychologists, providing this support in Hungary and then in the UK as well. What was very interesting is that as compared to any kind of psychological support that I had been part of before, was in person. And here, of course, because of COVID, we had to be providing all services online. And so remote services seem to have differed in a couple of key aspects from in-person service provision. The first one was the fact that as in an in-person world, you would be going to the office at the convenience of the client and of the psychologist, but to an office, to a room where there's a service provider, and this is where you would be receiving the intervention or the psychological support. And all of a sudden, we were doing all of this on Zoom. So this is how much you would see of me at all times, and I would see as much as I can see of Charlotte right now when it comes to the patient or the client. So what this means is that what we call the counseling frames, they really changed. All of a sudden, that safe space that the psychologist's office would mean would disappear, and you would see my personal background. You can see my wall painted, and I can see the everyday life environment of my patient or client. Or in cases where the patient or client does not have access to a space where he or she could be alone, then the person would be doing the sessions from the streets or from even the bathroom. So those counseling frames would really change. This was one of the things that we observed. And the second one was that, interestingly enough, the remote service delivery worked really well for some clients, those who live with social anxiety. Those with social anxiety found it a lot easier to come to therapy in an online world. So that was a success. The key mental health problems that we observed during COVID-19 are, unsurprisingly, changes to eating and sleeping patterns, mood swings, depressive symptoms every now and then. And then finally, we also found that in cases where someone had already been living with a mental health condition, those mental health problems were triggered by some aspects of the pandemic. So, for example, we had some psychosis cases where the psychotic symptoms were triggered by the pandemic overall. And so it was due to this experience that I thought it made sense for me to start a psychology center by myself. This is how I founded AMCA Counseling. I had always thought about the idea that I could have my psychology center at some point in life, but it never really materialized. And so I wanted to leverage my experience in cross-cultural psychology, global mental health, and then being able to deliver services remotely. And so this is how I started AMCA Counseling a bit more than a year ago by now. And basically, we created a remote workplace mental health platform. We would contract with other businesses. So we would be the in-house psychologist for typically large corporations, delivering brief cognitive behavioral therapy-oriented counseling programs online and supporting their employees as such. We provide these services in different languages. So of course, we work in English. We work in Hungarian. That's just because I come from that country, and so I know it quite well. And then we provide services in Spanish and in Portuguese as well. I'm really hoping to expand this at some point to other geographies as well. As a matter of fact, we were speaking with Charlotte and her colleagues a few weeks back. And I think I mentioned that I'm planning to go to Hong Kong and then to Singapore later next year, in case if restrictions allow, to explore opportunities there and learn a bit more about that region of the world, as I had not been exposed to learning opportunities there before. So this is how we set up AMCA Counseling. And so this is where I am right now. One more thing I wanted to mention is that I'm also very passionate about equality of opportunities, in particular to the younger generation and to women in particular. So beside my cross-cultural psychology and global mental health work, I'm also working on a side project which is called Voices, and we are a community interest company, basically volunteers setting up career development programs for women in the early stages of their career. So that's something that is very close to my heart. So with that, I think I will stop talking for now, and I will open it up for questions or comments or thoughts. I walked you through my career journey so far, and I tried to highlight some interesting components of global mental health work and cross-cultural work. And I've just received a question from Haley on the chat, whether I could talk more about what developmental psychology is. Absolutely. So developmental psychology as a field is looking at, well, as the name says, the psychology of development. What this would mean is studying questions as to how we as human beings grow and learn, and how our psychology, our personality, and psychological reactions would change over time. So one of the key topics that developmental psychology would be covering is learning processes for humans. And it's really very interesting from the perspective that we would study how children at a very young age learn how to connect with other people, how we learn about how to behave in a society, how to learn social behavior, how to learn about quantities, how to learn language. So it has, to some extent, neurological components, to some extent, cognitive psychology, but it's really looking at this early age and development over the lifetime. Nevertheless, developmental psychology also looks at personality development in the teenage years and then in young adulthood, so over the course of the lifetime, but it grasps the developmental component, the growth component. How do I go from one life stage to another? On the chat, I will send you a few names. If you're interested in developmental psychology, it's worth looking at these scholars. So one is Piaget. He was a French Swiss, I think, psychiatrist a couple of decades back, a foundational scholar and scholar in the field of developmental psychology. He studied how children learn and develop, and studied how children would understand, for example, physical units, physical materials. So he did experiments, like one very simple and interesting one is you would have a glass that is very long, and then you would have a glass that is one glass very long and very thin, and then another one that is very short but very thick, and then put water in, the equal amount of water in both. And then very young children would believe that the very tall glass contains more water. So at what age would children understand that you can put the same quantity of water to different shapes? So these are the kind of experiments that he was doing, and he's the foundational scholar to developmental psychology. Then the other person who I recommend reading about is called Vygotsky, who was, if I'm not mistaken, a Russian psychologist. And he studied, again, growth and development. And he has a foundational theory on the fact that if children are exposed to a learning environment where they are given a challenge that is not too far away from them, not too hard to achieve, but they need to learn skills to achieve them, that promotes best their learning and development. And so this is foundational, because even nowadays, the way we would teach children, the way we would teach even adults, relies on the idea that I give you a task that is hard for you to complete, but you can do it. If I give you something, if I tell you to run a marathon of 50 kilometers tomorrow, and you have never run in the past year, you will not be able to do it. But if I tell you tomorrow you run 1 kilometer, the next day you run 1 kilometer and 100 meters, you're going to find it hard, but you will be able to do it. So this is Vygotsky's theory on child development. Someone is asking, what's something about autism that not anyone knows about? So something, from my perspective, something that many people don't know in the general, like, special fact. So something that many people don't know would be the fact that autism diagnostic criteria rely heavily on behavioral observation. And autism was first diagnosed in males who live with the condition. And so what this means is two things. So we rely on behavior observation, and the diagnostic criteria were based on the male representation of autism. So what this means that women who live with autism are much more likely to be undiagnosed or misdiagnosed. The female representation of autism, while the core symptoms are the same, the representation of them can differ. Women with autism are typically much better in hiding some of their symptoms, masking some of their symptoms. Their special interests are typically very different. One of the core diagnostic criteria to autism include restricted interests or having very special interest in something. And so for women, they would typically differ from special interests of men. And so this means that many women would be underdiagnosed or misdiagnosed. Something else that many people don't know about. I think some of you might have heard about the term Asperger's syndrome, which was considered to be part of the autistic spectrum. And the latest diagnostic framework, the Diagnostic and Statistical Manual for mental disorders, that is developed by the American Psychiatric Association, the latest version, which is the 5th version of it, does not include Asperger's syndrome anymore. It includes an overall autism spectrum condition. So it includes the spectrum, and Asperger's itself is not a specific diagnosis any longer. So here are some special facts.